Transporting a ventilated, critically ill patient is a potentially dangerous task. A structured approach to this process is essential. This vodcast reviews the basic considerations required before undertaking the transfer of a critically ill patient. In this vodcast, we will review the potential misadventures associated with transportation, how to prepare for departure, and how to make it run smoothly. Potentially, when transporting a critically ill patient, we are removing that person from a stable environment and exposing them to hazard. Line dislodgement, accidental extubation, agitation, and other detrimental events can occur in a setting that is not ideally set up to deal with them. Predicting these events may go a long way to ensuring the safety of the patient. When moving a patient, there is always the potential to accidentally dislodge something important. Tubing can become easily snagged around door handles, bedsides and other obstructions, or be dislodged due to the movement of the patient. Disconnection of the endotracheal or tracheostomy tube from the ventilation circuit can potentially go unnoticed for some time. If adequately oxygenated, falling saturations are a late sign of disconnection. Failure to address this situation is obviously a potentially life-threatening mistake. In addition to extubation, the tube itself may obstruct because of sputum retention and of biting of the tube. Patients may be quite settled in the intensive care environment, only to become very agitated during transit. This can be precipitated by movement, painful body parts being touched or bumped, or simply because they are confused by the new environment. Agitation can be dangerous, as it leads to dislodgement of tubing, falls, or even staff injury. Infusion pumps and fluids may run out during transit, and other drugs may be required. Failure to recognise this may lead to serious complications, such as acute hypotension. All equipment may fail due to flat batteries or due to mechanical issues. It is essential to consider the impact of these failures on the patient. Battery duration of important equipment must be checked and contingencies considered in the event of a failure. Just as in intensive care, the patient may suffer a range of potentially life-threatening events related to their underlying disease process or due to the treatment they're receiving. For example, patients may suffer a cardiac arrest, have a seizure, vomit, or develop a pneumothorax. You must be prepared to deal with any of the complications that you would potentially need to deal with in the ICU. For various reasons, things can go wrong in transit. Lifts may fail, theatre may need to postpone that tracheostomy for an urgent caesarean section, and so on. The route you plan to take may in fact be closed for renovations. Frequently, the critical care team that take the patient to another destination are not the primary team caring for them. It is important that you get to know the patient well enough before departure that you can plan for any misadventure. Review their history. If required, get a handover from the clinical staff looking after the patient. Know what has brought the patient to hospital, the progress so far, and how they've been managed. A number of factors will affect decisions you make for your transfer. For example, what carbon dioxide will the patient tolerate? Patients with injured brains should always have their CO2 controlled, while in other patients a higher level can be tolerated. Does the patient have any drug allergies? Is there an advanced healthcare directive? Does the patient have a spinal injury? Does the patient have an infection control issue, such as MRSA colonisation? Examine the patient. A targeted review is required using a systems-based approach. The ABCD strategy is recommended. Airway. Check the airway. What size is the tube? How far in is it? Check it on the X-ray if available. It is essential to know this information as it will help you recognise when it has become dislodged. How difficult was the intubation, and was there any specific issue related to the airway? This will assist you with your planning for an airway crisis. Ensure you are happy that the tube is adequately secured. Check the cuff pressure and ensure there is no leak. Breathing. What ventilator settings is the patient on? Is the patient breathing spontaneously, or are they fully ventilated? What are their saturations and carbon dioxide readings? Consider measures of lung resistance and compliance, such as the intrinsic PEEP, plateau pressure, and peak pressures. These are important, as changing values in transit may suggest the development of a problem. Listen carefully to the chest so that you have a baseline. Again, check the X-ray. If there is an intercostal tube in situ, do you know how to deal with it? Circulation. How stable is the patient hemodynamically? Are they trending up, down, or are they stable? What rhythm is the patient in? And have there been any dysrhythmias that you should be concerned about? What cardiovascular support are they on? Importantly, know what IV access you have for the patient, particularly a primary point of access to administer emergency drugs. You may wish to consider placing defibrillation pads on. Disability. How awake is the patient? Are they agitated or calm? And will this be a problem? What sedation is the patient on? Have they recently had a fit? Environment. Check out the environment around the patient. Consider the tubing, monitoring, and equipment that the patient is attached to. Ideally, the best person to take the patient is the most experienced person available. At least 2 adequately trained people should participate in the transfer, such as a doctor and a nurse. Roles for each person should be clearly defined and discussed prior to departure. Without exception, the person who accompanies the patient must be able to deal with anything that can go wrong. A great practice to adopt is to brief for your trip with your team before you go. Go through the preparations in A, B, C, D order, checking the monitoring, last look examination findings, and outline your plans for any potential adverse events. You should repeat this every time you move the patient, at key times, such as before departure, and at regular intervals. Anticipation for all the events listed previously is essential. Have a strategy to deal with each one of these problems. Think through in your mind what you will do if any one of these events occurs at any time during the transfer. In particular, ensure that all IVs are thoroughly taped down, the endotracheal tube or tracheostomy tube is secure, and that you have all the equipment that you will need to deal with a disaster. You should have immediate access to a self-filling bag valve mask system and suction to be able to ventilate the patient, and enough oxygen and emergency drugs at hand to immediately deal with the crisis. Remember, you will need to take anything with you that you'll need to deal with the patient. You should work on the principle that once you've left, that's all you will have. Most hospitals will have some sort of kit to take with you that has the equipment and drugs you will require. Ensure that you know what is in these packs, where the items are located, and that they are still serviceable. Other units have developed checklists for preparation that include mandatory equipment lists. Similarly, you need to know how your equipment works. Most units will have specific transport ventilation and monitoring equipment. You will need to have a working understanding of how to work and troubleshoot them before you can take the patient away from the critical care environment. All invasive pressure monitoring should be calibrated and zeroed. Assemble the drugs that you will require for the trip. These may include sedation, muscle relaxants, pressors, and other agents. Ensure that you will be able to get these drugs into the patient in a hurry. Identify an access point that you will use for emergency drugs and, if at all possible, a backup. Ensure that this access is in fact patent by flushing it prior to departure. If not already present, attach a giving set that you can provide the patient with a rapid fluid bolus with if required. Remember that due to the resistance of flow imposed by its length, a central line is a suboptimal way to give fluids rapidly. Ensure all access points are secured appropriately. Check the batteries of the equipment you're taking, particularly for critical items such as the ventilator and infusion pumps. It is also important to know how much oxygen you have available. Some ventilators, such as the Oxylog 1000 or the Bird Avian, are powered by the pressure of the oxygen cylinder instead of batteries and consume significantly more oxygen than is delivered to the patient. You should calculate how much oxygen will be consumed to obtain a guide to how long you can ventilate your patient. As a general rule of thumb, take at least 50% more oxygen than you estimate you will consume. Be aware of the size of cylinder you take, as standards vary in different regions. Wherever possible, try to rationalise the amount of equipment, drugs and fluids you take with you. Consider giving the patient bolus sedation instead of an infusion, or combine infusions together, for example morphine and midazolam. Consider the need for feeding. If possible, cease it and aspirate the stomach. Remove unnecessary monitoring such as central venous pressure or urinary bladder temperature leads. Empty drain, nasogastric and urine bags to make life easy, and consider changing underwater seal drains to specialised transport Heimlich valve systems. If the patient requires further sedation, consider instituting this ahead of time to ensure they are adequately asleep, particularly if paralysis is required. Paralysis has the advantage of giving control of ventilation to the medical team and prevents movement that may lead to dislodgement of lines and tubes. However, it requires adequate sedation and exposes the patient to different risks, such as limb entrapment and eye damage, and may have longer-term consequences. If the patient is alert, spend some time explaining what is going to happen, as this may prevent anxiety and distress during the process. It is also prudent to give conscious patients an antiemetic prior to departure, particularly if travelling by vehicle. Set up the ventilator ahead of time to ensure that it is working and tested. Consider ventilating the patient on 100% oxygen during transit to give you extra time should the endotracheal tube be accidentally removed. Change the patient onto the transport ventilator circuit early, particularly if they have sick lungs, so that you can be sure that the patient will tolerate the change. If time permits, test your settings by getting a blood gas immediately prior to departure. Monitoring should be appropriate to the severity of illness of the patient. A ventilated patient should have, at a minimum, ECG, saturations, capnography, including visible waveforms, and a regular measure of arterial blood pressure. Ensure that the monitoring equipment is set up so that you can see it clearly during the transfer. At all times during the transport, somebody must be allocated this responsibility. Consider the possibility that you could be dealing with this patient for some time. Ensure that you have eaten and taken the opportunity to go to the toilet. Make sure your personal protective equipment is available. Consider if you need other resources such as clothing, food, water, and money if you are transporting a patient to another institution. Ensure that your mobile phone is charged and that you have the contact numbers you need in case of emergency. You should spend time working out where you have to go. What resources will you have available to you? Will suction, oxygen, ventilation equipment, resuscitation gear and experienced assistance be available? Are there any obstructions that will prevent the journey occurring? If transporting by vehicle, make sure you're aware of the resources and layout that the vehicle will have. This is particularly true for power, gas supplies and suction. All equipment and monitoring must be secured before departure for the safety of both patient and staff. Remember that if transporting via vehicle, access to the patient may be very limited. It is much more noisy and you have less access to resources. Transporting patients by air has specific challenges, which will be dealt with in a separate podcast. Think about how things will need to occur in the destination environment. If the patient needs to transfer from one ventilator to another, when will this occur? Where will the IV pole go? Will this be in my way? Where will the monitoring be so that I can see it clearly? Special environments such as MRI or the cardiac cath lab present specific challenges. Finally, before leaving, ensure that you have let the destination know so that they can prepare for your arrival. Also, notify your colleagues that you are leaving and hand over any responsibilities to them. Transfers are largely a team game. It is important that all members are informed of the plans. Team members can include medical staff, nursing staff, wardsmen to assist with transfers, security staff, and staff from the destination. It is often appropriate to have a leader to ensure the process works properly, particularly in the highly important stages such as moving the patient from bed to bed. Every effort should be made to ensure the team works in harmony. This is a well-recognised risk period for the patient. It is very easy for tubes and lines to be inadvertently dislodged, and great care must be taken. Someone must be given the responsibility to manage the patient's head and endotracheal tube. Failure to do this properly can result in endotracheal dislodgement. The cervical spine in unconscious patients, even those without suspected injury, can be subjected to considerable stress if not managed with care. This is particularly true if the patient is paralysed. Given this responsibility, when moving the patient from bed to bed, the person at the head end is often the team leader. The movement occurs on their instruction and the patient is moved as one. Before movement, try to anticipate what cables and tubing will come under tension and prevent this if at all possible. If unsure, the patient can be moved in stages. For example, move them halfway, then reassess. Unless the patient has critical ventilation failure, they can often tolerate a brief period of disconnection. If this is so, it is often better to disconnect the patient from the circuit during movement, such as when sliding from one bed to a CT table. The head and tube can be moved together by placing a hand behind the head and another across the mouth, holding the tube, as shown here. Develop a habit of checking the patient whenever moved, and at important times such as immediately prior to departure. Quickly review the A, B, C, D algorithm to ensure that there are no significant changes. Consider holding the tube as you transfer the patient through important transitions, such as bumpy surfaces and moving in and out of vehicles. Remember that the patient cannot protect themselves. Do not put equipment on the patient and ensure there is no chance of it falling on them. Take particular care of the patient's eyes. A high degree of vigilance is required when transporting patients. The transport environment can be very loud and distracting, so it is important to be disciplined in paying attention to the monitoring. It is obviously important to have a record of events during the transfer. This can be difficult if you are largely on your own, so develop a system whereby you can take notes of events and observations for documentation at a later date. Handing the patient over to the receiving team is also important. Ensure that your documentation is complete. Present the patient in a structured format if the patient is unknown to the receiving team, and ensure that they have the opportunity to ask you any questions. Moving the ventilated patient is a hazardous task. To reduce the risk of misadventure, a structured approach is important. In this vodcast, we have reviewed the most common adverse events experienced during transport and stressed the importance of preparing adequately for them. We have reviewed the preparation for transfer, including obtaining sufficient information about the patient to ensure that you can manage them safely, checking equipment thoroughly, and anticipating and planning for adverse events.